All right. One thing I wanted to let you guys know, if you wanted to keep any of the recordings, when I send you the Moodle link afterwards, make sure you download it to your computer because they disappear after 8 days. So the one from last week will disappear after tomorrow. So if you click the link, it's going to say it's not available. So if you want last week's recording to save, just to have to go through and look at or whatever at any point in time, make sure you download it. Same thing for this one. It's only going to be good for 8 days and then it expires. So if you want to keep it for some reason, just download it to your computer and then you can delete it when you're done using it. Okay. All right. So I have like a whole mixed pot of stuff to go over tonight because that's just how we roll in MRI. We don't focus just on too many of one thing and we throw it all together and send a ton at you. Yes, I'll send the link from last week again, and I will send tonight's link as well. So anybody who can't find the email from last week or whatever, I'll send it one more time. All right, let me get my screen here. So we're going to do like a quick kind of little review of what we went over last week, just to make sure everybody's kind of understanding and remembering. You know, that's our goal, is to have you actually remember the material and not just short term it. We want you to have it for long term. So I'm going to blow this up just a little bit here. So this is our brain anatomy, just like we had last week. What is this? And you guys can yell it out if you want to. Corpus callosum. Excellent. Largest piece of white matter in our brain. What is the anterior portion here? Oh, it's on there. Never mind. The answer is there. So genu and splenium. I just read that it was on there. That was silly on my part. And what is this?
Cerebellum.
Cerebellum. Excellent. How about this triangular shape region?
Fourth ventricle.
Fourth ventricle. How about this round oval piece? Pons. How about the most superior portion of our brainstem? What is it called? What was it?
Brain. Midbrain.
Midbrain. How about the most inferior portion?
Medulla oblongata.
Perfect. And this master gland that sits right here, what is this?
Pituitary gland.
And what does it sit in?
Oh.
What's the structure that the pituitary gland sits in? It's kind of this shape of a saddle.
I forgot the name.
Anybody know? Actually means Turkish saddle, the word that we use for it. So sella turcica. Sella turcica is what the pituitary gland actually sits in. The sella turcica is part of the sphenoid bone. How about this area right below the sella turcica? What is it?
Sphenoid sinus.
Sphenoid sinus. Excellent. So air is going to show up dark on our images because there's no hydrogen protons to get any signal from. Good job. Which imaging plane is this?
Sagittal.
Sagittal. Excellent. Know your imaging planes. All right. So genu and splenium are the anterior and posterior portion of what?
Callosum.
Corpus callosum. Yes. Again, this is what we're doing that slice angulation with when we are setting up for our axial scan plane. So here is that demonstration again. We have the 3-plane localizer that we run. First thing we run when we put a patient in the scanner is our localizer to be able to see the anatomy and know what we're covering. The very low resolution T1 weighted scan only runs for about 15 to 20 seconds. Really has no diagnostic value whatsoever. So again, when we are creating axial scan planes of the brain, our slice angulation is going to be parallel to the genu and splenium of the corpus callosum. You can only see the genu and splenium in the sagittal scan plane. So we have to use that sagittal to set that scan up on. Slice coverage. Who remembers the slice coverage for an axial brain?
Oh, from genu to splenium.
No, that's our slice angulation. We're angling parallel with the genu and splenium, but what is our slice coverage? We need to cover from where to where?
The foreman.
Brain.
Yeah.
Foreman.
go. You got it.
I don't know the rest of
Foreman
the
magnum.
magnum.
All right, yeah. So foramen magnum through the vertex. Okay. So slice coverage means we're covering from what point to what point. Okay, so that's slice coverage. Slice angulation is just what anatomy are we angling with and how are we angling? You were on it. You were on it. All right. And landmark for the brain, it is the glabella. Yes or no?
Yes.
Okay, easy one. What's the landmark for the IACs?
Here.
Come on. What's the landmark for the internal auditory canals?
Is it the glabella as well?
It's the glabella. What is the landmark for the pituitary?
Glabella.
Glabella.
Glabella. What's the landmark for an MRI orbit?
Glabella.
Glabella. Do you see where we're going with this? What's the landmark for an MRA circle of Willis?
Glabella.
All right, got it. Everything in the brain. It does not matter. If it is contained in the skull, your landmark is the glabella, okay? Everybody's got that now, right? Glabella, everything in the brain. Yes. Don't let that be something to stump you. That is a trick question we love to throw at you because we want to see, do you question yourself? And we love to make you question yourself. That's our goal. So when we say, what's the landmark for the brain? And you say glabella, there's a good chance we're going to say, what's the landmark for the IACs? And you're going to say glabella, and we're going to go, are you sure? And it's that moment that you have self-doubt. And we want you to remove self-doubt. We want you to be confident in your answers. So everything, if it is contained in the skull, it's glabella, okay? Don't forget it. All right, what imaging plane is this? MRI of the brain. What was it?
Axial.
Axial, good. Again, be able to recognize your scan planes. There's only really 3 of them that we utilize. You should be able to identify all of them. All right, so here's some new anatomy, a little bit different than last week. We have the ventricles that we can see here. So frontal horn of the lateral ventricle. These are frontal horns. They're in the frontal lobe of the brain. That's why they're called the frontal horn of the lateral ventricle. Occipital horn of the lateral ventricle is in the occipital lobe. There's a reason they are named the way they are. Superior sagittal sinus, as you guys know, this is the largest venous dural sinus running right down the top of our head all the way to the back. And so our ventricles, they're these hollow spaces. They're filled with cerebral spinal fluid. Does anybody remember what produces cerebral spinal fluid? This is from cross-sectional 1. Does anybody know? It's the choroid plexuses, and we can see them often in those ventricles, especially on the, typically on a T1, you see them good because they get calcified and they'll show up. So it's the choroid plexus. All right. What imaging plane is this right here?
Coronal.
Coronal. Excellent. We have our cerebellum, which is the smaller little brain in the back there. And then we have this entire area. It's divided into a left and right. What is this section of the brain known as? It's the same on either side. It's just one's left, one's right.
Hemisphere.
It is a hemisphere of what, though? We have the cerebellum. What is the main part of our brain called?
Matter.
Not quite.
The
Cerebrum. Emmanuel got it. He put it in the chat. Cerebrum. Okay, so we have right cerebrum, left cerebrum. So remember, main part of our brain is the cerebrum. Smaller part is the cerebellum. All right. Now, basic MRI contrast. You guys should know this. This should not even be a question of doubt when we ask you these questions. You must know the contrast. So whenever we're looking at a T1 weighted image, our fluid and waters are going to appear dark. whereas the fat is going to be brighter. Okay, that is your T1 weighted contrast. So if we say, what does a T1 weighted image look like? You're going to say, my fluid is dark, my fat is bright. That's it. That's all we want to know. Now, difference, complete opposite, T2. What does our T2 weighting contrast look like? Our fluid is now bright, our fat is dark. Okay, so make sure you know these. These are questions that are basic physics questions that we want to know that you actually have a grasp on. Because when you go to your clinical site, day one, they're going to say, what image did I just run? And you're going to be looking through these images and you should be able to say, that's a T1 or that's a T2. Know your image contrast. All right, that was the end of that one. You know what? Let's do some spine anatomy before you guys get too far into that. All right, so we're going to do some basic spine anatomy, and then I'm going to throw in some pictures that are a little more complicated once we kind of establish the basics, and see if you guys can remember from what we learned from the basic stuff. Blow this up, and we're going to start at the top so you can see it. Can everybody see it okay? Kind of a smaller image sometimes. All right, so based off of what you guys have already learned from the brain, you should be able to answer some of these. So who knows what A is pointing to?
Is it the cerebellum?
Cerebellum.
Exactly. And when we do spine imaging, especially our cervical spine, we often see the lower portion of the brain and the brainstem. How about L? What is L?
Pons.
The pons?
Pons. Okay. So now let's dive into some of this spinal anatomy here. This long, dark structure stretching the whole way down that B is pointing to. What is that?
Spine.
Spinal cord.
Spinal cord.
Spinal cord. Yes, spinal cord. Now, what is the bright
CF.
area?
CSF.
CSF. Good.
Spinal
So this
cord.
means this is what, a T1 or a T2?
T2.
T2.
Two.
And we know that because we know our fluid is going to be bright on a T2 weighted image. Good. All right, a little bit tougher now. D is pointing to the structure that's coming out the back. There's quite a few of them. You can see them the
Spinal-
whole way down.
Spinal process.
Spinal process of vertebra.
Okay, spinous process. So remember, you have that vertebral spinous process that sticks out your back. If you run your fingers down someone's back, you can feel all the little bumps where that spinous process is. Good. All right, let's work our way down here. How about E? Who knows what this structure is?
Sphenoid?
No. Cock.
Sacrum.
Sacrum.
Oh,
Sacral vertebra?
Sac-
Okay,
Body.
so,
sacrum.
okay, so it's a vertebral body and it is a sacral vertebral body. Now, which sacral vertebrae is this?
First.
First.
Good. This one has that more triangular shape. It's a little easier for us to identify because it kind of gets wider as it's more superior and it's more narrow at its inferior portion. We love this because it helps us count our vertebrae when we are doing lumbar spines. So we look for this to make sure we are starting on L5 and including all the way up through L1. So this is like a landmark for us visually. So you want to be able to identify that S1 vertebral body. How about F? What is this area here?
Intravertebral disc.
Intervertebral disc. Which one?
Oh.
Lumbar.
It is a lumbar. Now be more specific.
L3.
Okay, where that's the start.
L3.
Between
L-
4 and 5.
There you go. L3, L4 intervertebral disc. When we refer to a disc, it's named for the vertebrae above and below it. So when you learn to count your disc, it's going to have the name of both vertebrae surrounding it. So this one is going to be L3, L4 intervertebral disc. How about G? Who knows what G is?
It's thoracic.
Vertebra body.
Vertebral body. Yeah.
Okay, which vertebral body is it?
Which one?
12th
Okay,
Yeah,
thoracic.
T2.
12 of which
Thor-
vertebral section?
Thoracic.
D12.
Thoracic, good. So 12th thoracic vertebrae. How many vertebrae do we have in our cervical spine?
Is it
7.
32?
20,
7. How many vertebrae do we have in our thoracic spine?
12,
12.
How many in our lumbar?
5,
How many in our sacrum?
4.
5.
5. How many in our coccyx?
3.
3 to 5. This one is the goofy one where it can change. People actually have different numbers. So anywhere from 3 to 5. All right. Now that we know that, what is H? I'm going to scoot down. Sorry if you're trying to watch. What is H pointing to?
it's thoracic vertebra again. But I think it's
Vertebral body. It's,
Which vertebrae is it though? This is where you learn to count those vertebrae.
7.
5th.
7. It's the
Seven.
7th thoracic vertebrae. Good job. How about, does anybody know what J is? Right here,
is
Sternum.
sternum.
part of the sternum. What is this? This
Notch.
little dent here,
Notch.
suprasternal notch. Okay, that's what it's pointing to. How about K?
Atlas.
Which vertebrae is it?
C.
Cervical too, or
Aaron, you are correct,
C.
but would,
it's first.
or I'm sorry, you're almost correct. You're right below it.
It's C3.
C3. Okay, here's where this is where it gets confusing with the cervical, because when you look at it in a sagittal, you only see C2 because of that odontoid process, because C1 goes around it. And when we're doing a sagittal scan plane, we're not cutting right through it. So you can't see it at all. We would only see the posterior arch of C1 and the anterior arch of C1, which you can't even see the anterior arch on this one. So when you see this triangular shaped vertebrae, this is C2. And that's where you learn to start counting. So C2, and then you're going to count 3, 4, 5, 6, 7. That's all we have in the cervical. So now we know we have T1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. And then as we work our way down, we know we only have 12 thoracic. Here we have L1, 2, 3, 4, 5. Again, you learn to count backwards too. You find S1, L5, 4, 3, 2, 1, and you can count all the way up. So you have to have landmarks to look for. Anybody know what this is right here? The little white spot?
Artifact.
It's epidermis. No.
Vitamin E marker. Good. Some of you got it. Vitamin E marker. So a lot of scanners can now do a full localizer from, and this is pretty close to one, where you can get all of the vertebral columns. So you can count really easy. The older scanners, which are quite a few of those out there, we used to stick a vitamin E marker on our spine coil. And then the patient would lay on it and we would use that to localize where we're at. So we would run a cervical localizer and then our thoracic, and we could look and see where did this vitamin E marker show up. See, there's one up top and one at bottom. So we know this one's going to land roughly around C7, but we count from here and we'll find it. And then as we work our way down, we know this is T7. So in between T7, right about T8 is where this marker is. When we set up our scans, we know that that vertebrae is T8. So we know how far up to go and how far down to go. It's just something we would use to visualize, because we can't put the whole entire thing on every scan. It would take us forever in the day to run from the cervical all the way to the lumbar. And we really don't have coil coverage for that either. All right, guys, good job. So now let's look at just a cervical. Is this T1 or T2?
Which one?
What was it?
T2.
Oh, T2.
T2, good. We know that because again, the fluid is bright. What is A?
Where is A?
Fourth ventricle.
Fourth.
Right up here is A. This is the fourth ventricle. How about B?
Cerebellum.
Good. So see, that brain anatomy is paying off for you guys now. How about this little piece of bone right here? I talked about it a few minutes ago. What is this? It is part of C1, but specifically, what is that portion called? Anybody know? No, odontoid's part of C2.
Odontoid process.
So this is the posterior arch of C1. Remember, C1 is kind of rounded, and we have an anterior arch and a posterior arch. So as it sits on top of C2, there's an anterior arch and a posterior arch, and that's what we see in the sagittal view. You don't always see both at the same time. So posterior arch of C1, what is D?
Spinal cord.
Spinal cord.
Good, easy one, right? What is E?
Cerebral spinal.
CSF, perfect. Now we're gonna get into some ligaments. And this is where it gets tricky with the spinal canal anatomy because a lot of times these ligaments get really confusing. There's so many. So we're looking at this ligament that's stretching down over the tops of the spinous processes. So those bumps you feel down your back, there's a ligament actually attaching each one of those. Do you guys know what this ligament is called? Where F is pointing?
Is it the transverse?
So these are the spinous processes that they are attaching the very ends of. This is the spinous ligament. You may hear it termed supraspinous ligament as well. It can be called either one, but spinous ligament, think of the spinous process, the ligament going over the tops or the edges of them is the spinous ligament. Now we have a couple ligaments that run down on either side of the vertebral bodies. So we have one that runs posterior, the whole length all the way down, and we have one that runs anterior, whole length all the way down. Posterior one, does anybody know the name of this?
Posterior vertebral ligaments.
That is actually a really good guess. Posterior longitudinal ligament. It runs the whole way down longitudinally. So posterior longitudinal ligament. Knowing that, what do you think J is?
Anterior.
Anterior longitudinal.
Exactly. Okay. So your anterior longitudinal ligament is on the anterior aspect of the vertebral body. Your posterior longitudinal ligament is on the posterior aspect of the vertebral body. So the vertebral body is sandwiched between these two ligaments. All right. Which one are we missing here? Oh, G. This little white area here that you see, this little hill of, we're going to say it's some sort of fluid. Does anybody know what that's called? We see this frequently throughout the spinal column. You can see it on every single vertebral body. It just depends on the slice you're at, if you hit it or not. Anybody know what that little, what is it?
Transverse pedicle?
Nope, it's bright. So think about something that might show up a little bit bright. So this is actually our venous plexus. We have venous plexuses all over, but we can see them on the backside of our vertebral body, and they're just these tiny, tiny little tanglement of veins. And because they're all kind of entangled and there's so many of them, you can see it as a brightness on our T2. All right, so now we're looking at the thoracic region. What scan plane is this?
Sagittal.
Good. Yeah, same thing we've been looking at for a while. Is this a T1 or T2?
1, 2.
Two.
Perfect. Yes, good catch. T2, because again, our fluid is bright. What is A?
Vertebral spinal cord.
Spinal cord, yes. And it is surrounded by what? This is what D is pointing to.
CGF.
Cerebral fluid.
Yes.
Yes. CSF, good.
CSF.
Where do we find cerebral spinal fluid? What space in the spinal canal do we find it? Anybody know?
Around the spinal cord.
It is, but where? Remember, there's layers to that spinal cord. Ah, there we go, Leah, you got it. Subarachnoid space. Okay, your cerebral spinal fluid is going to be found in the subarachnoid space. That was just a side note. All right, so now going back to ligaments, ligaments are going to appear black on our image. They're going to appear very dark because they're a thick band. There's not a lot of hydrogen protons in them, so they appear black. And we have this ligament that we can see that runs between every spinous process. Anybody know what this is called? It's going to run down in between every one of these. Any guesses?
Interspinal ligament.
Good guess, actually, really good guess. But another note on this, if you were to ever see it in a cadaver, it's yellow. It is a yellow ligament, almost a bright yellow ligament. This is our ligamentum flavum. And you're going to see it in between every little spinous process on the anterior aspect, right behind that spinal cord. So ligamentum flavum or ligamentum flavum, it's another one of those tomato things where people pronounce it differently.
Ay, naku. Mamaya restart mo. Ano na siya?
All right, what is C?
Spinal process.
There you go, spinous process. D, we already talked about cerebral spinal fluid. What is E?
Vertebral body.
Body.
Yeah, we can't count this because we can't see anything to tell us where we're at. You can see that when this scan was done, they used a vitamin E marker, but we don't know where the location is of that. We don't know because we don't have that cervical spine localizer to count down. So when you can't tell, it's just the vertebral body. What is G?
Intervertebral disc.
Intervertebral disc. Anybody notice anything wrong with G?
G.
G is in George. What's wrong with it?
It's
All right, yeah.
Bulge and
So we have a slipped herniated disc here. You see this bulge? That's where the nucleus pulposus is being squirted out because it got squished somehow. So remember, with your intervertebral disc, you have your annulus fibrosus, which is like the harder, more coarse capsule of the disc. And then inside of it is a gelatinous portion, which is known as our nucleus pulposus. So whenever your disc herniates, it's the nucleus pulposus that's getting squished out. So this is what you're seeing here is herniated disc. There's also one at this level as well, one at this level as well, and a small one here, and a small one here. Oh, there's another one. This person's just got tons of little ones, tons, but it's the bigger ones that cause a lot of problems. All right, what is H?
Notch of sternum.
Suprasternal notch.
Notch
You
of-
can feel it right there, this little dent in your neck, suprasternal notch. Actually, herniated discs are painful when they start to put pressure on your cord. So some of these really small ones, a lot of times the patients don't notice them because notice how there's still CSF getting through and it's not really impinging on that cord. But when you get bigger ones that start to touch the spinal cord, that's where they get the pain because it's causing that inflammation of the spinal cord. It's putting pressure on the nerve itself. So that's where they start to notice that. All right. I think that was everything on there. Oh, well, what is F? I missed F.
Body of sternum.
Sternum. Good. Yep. All right. What scan plane is that?
Axial.
You.
Axial. Does anybody know if this is cervical, thoracic, lumbar? Any guesses?
cervical.
Okay, yeah. So there's a localizer on here that you can see. So that helps. Whenever you don't know, you can look around a little bit on your pictures and there's often hints. Does anybody know another way to tell that this is a cervical vertebrae versus those little pictures?
Body's smaller.
They are smaller, but what else? Anything else? There is one specific feature that cervical vertebrae have that the rest of the vertebrae don't have.
Those two things that have like little wings on them.
Little wings. I
Well,
like the
why-
description. All right, so here is what will help us. It's shaped like Sid from Ice Age. I appreciate that. That's good.
Oh my god.
And actually, I never saw it, but now, oh my gosh, now I can see Sid's face completely. That is totally off subject, but here's his eyeballs. Here's his face. Oh, you totally did it. Now that's all I'm going to see. All right, so back to all seriousness. We have two blood vessels that run up our neck into the circle of Willis that run up through the transverse foramen of our cervical spine. Our cervical spine is the only area that has openings, foramen, in the transverse process. Your thoracic does not have those. Your lumbar does not have those. Nothing, no other area has foramen in the transverse process. So
It's
here's
like
our,
artery. Sorry,
what's that?
protecting for carotid artery.
It's the vertebral arteries. That's how they get their name. They're running right up those vertebrae. So yeah, so the vertebral artery is what you're seeing right here. Okay, that black hole there, and it's coming right through the transverse foramen. And it's just guiding those arteries right up into the brain. All right, now that we know that, what is A? A is pretty simple.
A.
Yeah, A.
I can see a. Oh yeah, it's cerebrospinal fluid.
Exactly. Which means this is what, T1 or T2?
T2.
Good. Yeah, we've looked at all T2s tonight so far. So yeah, cerebral spinal fluid. So what is B?
Spinal cord.
Yeah, going
Mhm.
right through that spinal fluid is going to be our spinal cord. Excellent. Now comes the tricky part. We're going to start looking at the bone anatomy. So we have, what is this
Body.
here?
Body.
Vertebral body. Excellent. What do you think this is right here? It's going between the transverse foramen and the spinous process.
Pedicles.
Not the pedicle. So coming off that vertebral arch, first you have your pedicle. Your pedicle is attached to the vertebral body and expands backwards towards the vertebral arch to the transverse process. From the transverse process, we have this little bridge that's between the transverse process and that spinous process that sticks out the back. Anybody remember? Oh, there we got it. Leah, I just now saw that you put it. You are correct. It is the lamina. So the lamina is going to be between the transverse process and the spinous process, which our spinous process is right here. And then let me see. I don't think you can see the pedicle well enough on here. No. Let me move my chat box on. All right, I don't see a good, we'll look at one with the pedicle really well so you guys can actually see it. This one is more for demonstrating our nerve roots. We have two nerve roots that come out from underneath every vertebral body. Does anybody know the names of those two nerve roots? This is why we do our axial scans, is so we can evaluate that spinal cord and all those nerves coming off. So we have a dorsal and ventral nerve root that comes off of our spinal cord. Okay, again, underneath every vertebral body, these are exiting. So we can use this to evaluate these axial slices to evaluate them because we can see them coming off. We can see if they're inflamed. We can see if they're enlarged. We can see if there's any damage done to them at all. So here, D, this dark line you see, this is our dorsal nerve root, most posterior, meaning dorsal, towards the back. Then we have one that's coming off anteriorly. This is our ventral nerve root. Remember, ventral means towards the front. So the anterior one is ventral nerve root, posterior is dorsal nerve root. G, we all know what G is, right?
Spine of
Spinous process.
You got it. Spinous process. J, we talked about this. What did we say it was?
Transverse process.
foramen.
Well, it's going through the transverse foramen, but this is
vertebral foramen.
not quite. This is actually the blood vessel. What blood vessel is it?
Artery.
Which-
Carotid artery.
Vertebral artery. Karen got it. Vertebral artery. Good job. And then lastly, H. Okay. Here's our lamina. Here's our spinous process, lamina. What's the lamina fall between? Spinous process and
Transverse process.
transverse process. Good. All right, let's look at one more axial and then we're going to take a break from the spine. All right, anybody know if this is cervical, thoracic, or lumbar?
Cervical.
Okay, any other guesses?
I would say
Thoracic.
All right,
thoracic.
I got cervical, thoracic. Anybody want to throw a lumbar or sacrum in there? Or are we all set on cervical and thoracic?
Thoracic.
All right. So how would we know if we're looking at the thoracic? We learned that the cervical has the vertebral or the openings for the vertebral arteries, so the transverse foramen. What's unique about the thoracic region?
Are those the lungs?
Yeah, there's lungs.
You're gonna still have lungs up here close to like C7 and stuff as well, but that is a good hint. Some people who are super barrel chested from their COPD, you might see some lungs in the lumbar too. But what is our main key thing to look at? It's attached to our thoracic vertebrae.
The costs.
Uh,
Ribs.
The
Cage,
ribs.
the rib cage.
Ribs. So you're gonna look for these ribs coming off of each vertebrae. You see ribs, you know you got thoracic, okay? All right. What is this right here? It's not labeled, so I'm just saying this.
Body.
Vertebral body, good. What is B?
B.
Spinal cord.
Spinal
Spine.
cord.
Spinal cord. What is C?
Spinous
Spinal
process.
process.
Good. How about this region right here?
Lamina.
Lamina.
Lamina. What is surrounding B?
CSF.
Cerebellum, spinal
ESF. And now we have this little vein. We do see this a lot on our thoracic. We'll see it sometimes even down into the lumbar region. Does anybody know what the name of this vein is?
Thoracic vein.
So this is our azygos vein. This is one of the larger veins. It runs up our posterior thoracic cavity, and it's draining the blood from that thoracic region, that posterior thoracic and lumbar region. So it's a pretty decent sized vein. We actually get it when we do our axials. You can see it pretty well. All right, let's take a break from spine. You guys did good on that.
Is it tumor on the lung? A.
Wait, say it again, Karin.
What is A?
A. Oh, does anybody know what A is? I totally skipped that.
I think it's tumor.
Aorta.
It's the aorta.
There.
Remember, blood is usually going to show up black unless we're using contrast for some reason, because does anybody remember why? Anybody know why blood's showing up black?
It's moving.
That's oxygen.
Moving. So
or-
when you use your slice select gradient and you say, I'm going to excite the spins in this particular slice, and you send that RF pulse in and you excite those spins, and then guess what? You turn the RF off. It's going to start to relax back, give off signal. Well, the ones that you excited are gone. You can't get signal from them. Okay, because you're trying to localize the signal from that slice that you in particular selected to scan. And now those hydrogen spins that were in the blood, they're probably to the brain. They're gone. So you can't detect signal from it. So therefore, it's going to show up black. All right, good job, guys. All right, let's take a
T2, right? This one's a
What's
T2.
that?
Was that a T2? That was a T2.
It was, yeah, everything we looked at was a T2. All right, let's look at some physician orders now, because you guys need to be familiar with these. What do we need on a physician order? Signature. Signature. What else?
Name of the patient, their birth date.
The date of birth. Mhm.
Diagnosis.
Contact number.
Diagnosis. What was it?
Contact number.
Which number?
Contact.
Contact.
Say it one more time.
Contact, I think.
Contact number.
Contact. Oh my goodness, I'm so sorry. Like I could not. Yeah, good job. We want to have the contact info. A lot of times your doctors will give you a standard order form. So it may go to a facility that they work for and may not have it actually written on there. but otherwise it should have their contact information. What else?
The kind of exam you're doing.
Kind of exam we're doing. Good.
Position
Anything else?
number.
Signature of a physician.
Signature of the physician. It's going to have our diagnosis. We need to know why we're doing the exam we're doing. So we need patient name, patient date of birth. Those are the two identifiers that we check, and it's going to verify that this order does go with that patient. We need to have the diagnosis, or at least diagnosis code. We need to have physician information, physician signature, and then of course the exam that we are going to perform. We want to make sure that our exams make sense with the history. So this one here, we have an MRI of the brain. What does those little symbols mean? Anybody know?
Contrast.
Contrast.
What about contrast?
Is it with?
One with contrast.
Yes.
So you're going to see this written like this all the time. So
What is that?
this
An F or a 3?
So this is a C with a line over it, and this is an S with a line over it. Does anybody know what the C with a line over it means?
Without
No.
contrast?
With contrast?
Without contrast.
So C means with contrast.
Eesh.
S with a line over it means without.
Oh, wow.
So almost always our exams are going to be either ordered MRI without or MRI with and without. We're not going to run an MRI brain with contrast only. It would make no sense. We need the comparison. So if you see an order for MRI brain with contrast, you're going to call the physician and say, hey, we need to have it with and without, or your facility's protocol might be, since it's not adding a contrast injection, it might be that you're able to actually just change it on your own. But a C with a line over it is with, an S with a line over it is without. Does
Why do
anybody
they
know
write it like that?
what's
Sorry.
that?
Why do they
that's
write
okay.
it like that?
It's just short. Honestly, if you look at the CTs as well, how they have a plus and minus, or this one just has a minus. So you may see it that way where it just says plus C, plus minus C, but a lot of physicians still write just with and without. So definitely know that. Does anybody know what a P with a line over it means?
Pulse.
After. A P with a line over it means after. So you may see that sometimes written in orders as well. All right. What is our MRA brain? Do you think it's with and without contrast, without contrast? What do you think?
Both. We have to do pre and post contrast images.
For the MRA of the brain?
Angiogram. Yeah.
Okay, so an MRA brain, we don't give contrast. We use our time of flight imaging, and we do not need to give contrast for that. Because it's a smaller area, time of flight does a very, very good job of imaging that area. So an MRA brain, even if they wrote with contrast, you don't give contrast for it. So do you think we need to do the MRI brain first and then the MRA?
Oh,
No,
hold on.
doing the MRA first and then do the MRI afterwards.
Yeah,
It-
so actually you could, go ahead, Mike.
If
Mikhail, what is it?
if you gave them contrast, then it'll mess up for the MRI, you know.
Yes,
you
we
gave
don't
them
want to
contrast,
do an
it'll make it-
MRA with the contrast if we're using time of flight imaging.
Yeah.
And we would never actually image it with contrast because it's going to burn out those vessels for us, make it harder to see. So it would be very, very rare that you would do an MRA post contrast for a brain. Now, MRA of the carotid, we want to use contrast because it's a large area. It would take us forever in the day to run that same scan. And then we're going to have motion everywhere. So we want to use contrast on the carotids. So we would run our MRI brain without, our MRA brain, and then inject and run our MRI brain with. Okay, so you'd run your full pre-contrast brain, run your MRA, and then run your without. Or you could do reverse. You could do the MRA first, run your full MRI without, and then do your injection and do post brain. So as long as it's done before the contrast injection, it really doesn't matter at what point you do it. And everybody does whatever they want with that typically anyways. All right, so let's see. All right, everything was on there. Here's another one. Okay. So what type of order are we doing? What is our scan going to be?
Brain with and without.
The brain.
Brain with and without. Good. Again, we want to make sure that we have what? What are the things we're looking for?
First name,
Patient's
last name.
name, date of birth,
What else?
physician signature.
Okay.
Contact info.
You said
Mhm, what else?
diagnosis?
Diagnosis or a diagnosis code. Absolutely.
Make sure
Now-
the date of the GFR is well, the exam day is the 3rd. The GFR was on the 21st.
Yeah,
Yeah.
GFR was on September 21st.
Mhm.
They're having the exam on November 1st and the order was written on, or I'm sorry, they're having the exam on November 3rd. The order was written on November 1st. What are you seeing? What's
They
wrong?
have to do it again, right?
More than
They
a
would have to
month.
do they would have to do another,
They have to do another GFR. Why?
because it's over
Over
30 days.
right?
Over 30 days. Excellent. Notice on here, this patient is getting another exam. What's the other exam that's ordered? Can you see that? Is it too small?
Head CT.
A head CT, is it with and without contrast?
Yes.
Oh, yeah.
Where do you see that?
So, here, let me
Oh,
zoom
yeah,
in on
yeah,
it.
yeah,
Can you
yeah.
see it?
I see it, yeah, I see it.
Okay. So which one of these do we have to do first? The MRI brain with and without contrast or the CT with and without contrast?
Can those both on the same day?
Without,
Yeah.
Yeah.
Well, CT and MRI are different modalities, so they're going to have to go complete one exam and then come to another department and complete the other exam. So they can't do like CT head without, ship them to MRI, do the MRI head without, and then whatever. So we both give contrast. Do you think one of us have to go first, or does it not matter?
Mm.
Come on, give me a guess. It's a 50-50 shot.
MRI, yeah.
CT first, then
I would
MRI.
say CT. Yeah, CT and
Okay,
then
so I'm
MRI.
getting all this CT, MRI first. Great. So you all made a decision. Why? Why do you think CT or MRI needs to be first?
Because CT is faster.
Contrast.
Yeah, CT's
CT
fast.
is faster. And when they're both given contrast, are they given the same type or a different type of contrast?
Different.
Different.
Different. So MRI contrast, gadolinium, is more of an iron-based contrast, and CT contrast is iodine-based contrast. Here's the kicker. Our contrast shows up on CT. CT contrast, we don't see. Knowing that, which one needs to go first?
CT.
CT. Yeah, and you often won't find this being an issue, but if you're in a hospital where a patient's getting everything ordered left and right, and you see an order come through for an MRI of the brain with and without on your patient, you go into their chart, you're looking through stuff and you're like, oh, well, they're getting a CAT scan too. Now you need to pick up the phone and be like, okay, I need this patient when you're done. That way you don't inject them and they see the contrast on their study. Again, very, very rare that you're going to encounter this unless you are in a hospital where your patients are getting ordered 50 studies in one day, which you will see happen. So, and yeah, again, you're overloading those kidneys with contrast. So it's not recommended to do it, but if the patient's got all these orders, we do them back to back. So of course, making sure that GFR is good before you do anything. All right. Screening forms. Can you guys see this? Is it too small? I can blow it up.
I can see it.
I can see it.
Y'all can see it? Okay. So Jasmine, this is going to be your screening form. What do you see wrong? What are you going to ask me if I'm your patient?
I just can't see the bottom. Like of the
The bottom's just the signatures. Don't
okay,
worry
okay.
about those right now. Yep.
Look at this, start with the top.
Yep. You start You're reading it just like you would a book. You're going to start at the top and work your way down. So I handed this to you and now you're going to look at me and screen me. Do your verbal screening.
Well, I see that they've said yes to for the heart, for the medical stent filter wire mesh.
So what are you going to ask me?
Like what have you had done like for your heart? Like what surgery have you had?
Okay, so now I'm going to tell you I had a stent placed. I had a cardiac stent. What's your next question?
Um,
Lifeline, lifeline.
Nope, this
Yeah,
one's hers.
please.
Don't you all cheat. Okay, I have a cardiac stent. What else do you need to know about that stent?
Milk and powder.
Do you know what a cardiac stent is?
I kind of forgot. I'm not gonna.
Okay, so a stent is this little mesh shaped kind of rounded structure. It looks kind of similar to like a straw, little tiny straw. And they're going to put it in a blood vessel in the heart, or they can put it anywhere really, but typically you're going to find it cardiac stent is the most common. But it's this tiny little, looks like a little straw. They put it in a blood vessel that's got a lot of plaque buildup in it and the blood flow isn't good. And it'll actually expand and open that blood vessel up. They use an angiocath. Okay, the stent is going to be over top of this balloon and they go up in, they put the stent where they want it and then they blow up this balloon and it pushes the stent into the wall of the vessel and also pushing that plaque out of the way makes it wider so that the blood flow can get through. So now that we know what a stent is, what do you think you need to ask me?
Well, I would probably ask like how long ago you had it placed.
Yes. And I'm going to tell you 8 weeks ago.
I believe that's like okay, right? It doesn't have to be after like 3 weeks.
It has to be 6 weeks.
Okay.
6 weeks. Some stents now are being made, they say are safe to scan right away, but typical rule of thumb for us in MRI is 6 weeks because enough scar tissues build up around that stent. It's not going anywhere. Even if it's a conditional stent, it's not got enough pull or anything. That heart is putting more pressure on that stent than we will ever will with our field. So 6 weeks. If I told you it was like in the last 4 weeks, what would you tell me?
I would probably have to reschedule because it hasn't been for the 6 week mark.
No, you could ask me for my implant card and investigate it because maybe it's one of the newer ones that is safe to scan right away. Okay. 6 weeks, you're pretty golden. You don't have to ask for an implant card. It's not going anywhere. Prior to 6 weeks, we're going to need the implant card if we're going to scan them that day.
Okay.
All right. What else do you see, Jasmine?
I see that it's noted that the reasoning is because of the head hurts.
Okay.
For 2 weeks. They probably ask if they've, I don't know, taken anything for it.
Okay. Yeah, for history.
And ask them, ask them, like, did anything happen? Did they?
Good. Yeah, you want to ask that history
And then
get.
they put a question mark for prior surgery. So I probably, I don't know, investigate a little bit more about that.
So this is where those flight. Go ahead.
Yeah, I would say just like explain like what type of surgeries if they've had.
And see, that could open up a whole can of worms because if they put a question mark, so this is where that flight attendant questioning comes in. Have you had any surgeries anywhere in your body, head to toe? You know, have you had surgery to your head, your eyes, your ears, your chest? Because sometimes just pointing to an area triggers it. And honestly, this is just the cardiac stent is what the surgery was going to be, which really doesn't even qualify as a surgery because you're only going up through an artery, but that's what we would be. That's what I'm saying it is. Anything else here?
And then they checked yes for the, are you diabetic or have renal disease?
Okay, so do we care?
yes.
Why?
So yes. Because some scans, it may take longer, and you need to know how long they can go without having their, like for the diabetes, the insulin.
Okay, well, they don't have any insulin pump. They mark no to that.
Where?
Right up here, electronic implant device
Okay,
or
yeah,
insulin pump.
okay.
So, do we care if they're diabetic or have kidney disease, whichever it is?
Well, yes.
Why? These hard questions, but see, this is
Like,
good
I
practice.
know. I know, just being on the spot too. I'm just like, it's just like kind of nerve wracking, because it's like I know it, but then it's like when I have to talk about it.
I know, and
I
that's
get
really normal,
stuck,
but this
yeah.
is how clinicals will be. So we want you to be confident and comfortable in your answers. So just tell me, do we care if they are diabetic or have kidney disease? And if we do, why? And if we don't, why?
Say no.
Why not? Because they're not giving contrast. Our concern with this would be that we are going to blow their kidneys out if we give them contrast, because their kidney function is going to be poor, possibly because they're diabetic or they have kidney disease. But we're not giving contrast. So with this, we would just breeze over it. Okay, they're diabetic, they have kidney disease, one of the two, but we're not giving contrast today. There's that S with the line over it. All right, anything else you see, or are we good?
I think it would be okay.
So you didn't ask me anything about my body piercing, tattoo, or permanent makeup. You did skip that one. So you got to be careful not to skip things, okay? It should at least raise a question. It says ears. So you can say, do you have earrings in currently, or do you have a tattoo on your ear? Which one is it? And just verify. If they have earrings in, what are we going to do?
Have them remove them.
Have them remove them. What if they can't remove them?
Couldn't you place like something over them, so in case, like, to prevent from the heating?
Well, we're doing the brain, so we would really like to get them out if we can. But yes, if we can't get them out, we can put something on there to try to hold it from being pulled, like a Band-Aid or some tape or something. But what can we do to make sure if it's ferromagnetic or not?
Oh, use like the handheld magnet.
Yeah, check it with a handheld magnet. Of course, we want to take them out if at all possible, because the brain, what's going to happen? If we leave them in, what's the problem?
Oh, it can cause like what is it, like the artifacts in the image?
Yeah, it's going to cause artifacts. All right, good job. I'm not going to pick on you any longer.
I'm like, no, I appreciate it. It's like when it does come time for the interview, I don't want to be, stuck.
Yeah, it's the thing. Know these screening forms for your clinical interview. Go through them. Know the answers to if it's a yes or if it's a no. Leah. Yeah, let me see. I just had a question and it's totally gone. Where did it go? Yeah, it's gone, Leah. Sorry, you're just gonna have to do a screening form now. Here is your screening form, Leah. Oh yeah, you got a bad one.
Well, first thing, they didn't answer for a bunch of the questions. They just didn't write anything.
Well, I gave it to you like this. Now you're going to talk to me like you're my tech. What are we going to do?
I would go back over it and ask them all the questions that they didn't
Well,
answer.
I'm your patient. Ask away.
Are you claustrophobic?
No. Do we need to ask the next question now?
No.
No, don't ever offer sedation to anyone, because you'll get that person who is a drug addict who's going to be like, yeah, I need sedation. You offered it, I need it. So if your patient says they're not claustrophobic, we don't even mention sedation. Okay, go on. What's next?
They marked yes for dentures or plates, but it's an MRI of the lumbar spine, so I don't think I'll have to take it out. It's not in the area of interest, so it won't cause artifact.
Okay, good. Yes, we do not have to remove them if it is not in the area of interest. It is not going to suck their dentures out, thank goodness. Go ahead.
Do you have a history of working with metal or metal in the eyes?
Yes,
Oh, then we would have to order an orbit x-ray before.
good. That prompt is on there for you guys for the reason of generating that thought. Good. Go ahead.
No. Yes to hearing aids. I would ask what kind of hearing aid or implant they have in their ear or eye.
Yeah. And so I'm going to tell you that I have a hearing aid. That's it.
Hearing
Just
aids
plain
can't,
hearing.
hearing aids can't go in there.
Right.
So I would ask them to remove their hearing aid because we have to give them hearing protection.
Or when are we going to remove the hearing aid?
Before you go into zone 4.
Okay. So what do you need to make sure to do before removing the hearing aid?
Screen them in zone 3 so they're not already in there with the hearing aid.
Well, yeah, you want to make sure your screening's done because if they can't hear you, but you also want to explain everything to them before you have them take it out. Otherwise, they're going to be going, what? Huh?
Yeah.
I can't hear you. Yeah. So make sure you explain everything. Okay. What else?
Okay, they marked no to pacemaker, no. They marked yes for an artificial limb or prosthetic. So I would ask them what kind of prosthetic they have and tell them that they have to remove it if it's a leg or an arm.
So I'm your patient. So you're asking me a question. What are you asking me?
What kind of prosthetic do you have?
I have an IUD.
And then IUDs, some of them are unsafe, right?
If it was made in China, it's unsafe.
Yes. but all the ones made here are safe, right?
Not safe. Typically, they're usually conditional, but they are pretty much safe to scan at every strength. Like certain ones like Mirena, you're going to find that you can always scan that. Even though it's conditional, you can always scan it. So you still need to look them up if you can. But I will tell you, and if any of you have ever had an IUD, you don't get an implant card for that.
Yeah.
You just don't. So typically we do rely on the patient to tell us what type they have. Most women are pretty knowledgeable about what's in their body. If they don't know, then we can do what?
We can try to, can we try to look it up in their medical history?
This is their first time coming to you. You don't have any medical history.
X-ray?
Okay, we could x-ray it. What is that going to tell us?
I was reading the chat that it's in there. I don't remember about these IUDs, what to do for them.
Okay. So if they don't remember, which again, most women do know the name of what is in their body, but if they don't remember, you can call the gynecologist office and say, I just need the surgical report. That's it. Get that. It's going to give you the name and then you can research that name. If you did an x-ray, again, this would be more your little Chinese, Vietnamese women who may have had one of these. These were like back in the 80s and 90s, they were putting them in, the ones from China. But some of the older women never got them removed. So those ones, if you did an x-ray, it's going to be circular. It's going to look like a key ring. Okay, that's how you kind of know which one that one is. All right, go on. What else?
You marked yes for a medication patch. Where is it and what kind of medication is it?
It's on my back and it's fentanyl.
How long can you go without it?
I really prefer not to take it off. They're expensive.
Is it clear or is it?
I don't know.
Well, well, I would have to look at it and make sure it doesn't have any metal pieces in it because that's be safe.
So now you looked at it and it is clear. What do we need to do?
It's clear, so I'd put gloves on and take it off and then face it on the outside part down.
So what would you do if it wasn't clear?
If it wasn't clear, do you leave it on?
You're backwards.
I'm backwards. Okay,
Clear.
if it's clear, you could leave it on, and then if it's not clear, you have to take it off. Because
Right,
if it's
why?
clear, you can see if it doesn't have the metal in it.
All the clear ones, none of them have metal in it.
Oh, so
The-
that,
the-
we're making
yeah,
these
the-
wrong.
The ones that you can't see through have that little piece of foil in them, and that's what can heat up and cause a burn. All right, what else?
They wrote that you have a body piercing, tattoo, or permanent makeup on your arm. Do you have a tattoo?
Yeah, I would start with that one. I mean, you
Never
never
seen an
know
arm
anymore, but that's the
piercing.
one I'd start with. Yeah. So,
How
yeah,
long
I
ago
have an
did
arm
you get
tattoo.
it?
What's that?
How long ago did you get it?
3 weeks.
3 weeks is okay for tattoos, right? 6 weeks for
You're
surgery.
an attack. Tell me. Confidence.
3 weeks is okay for tattoos.
Confidence. Yes. Older than 2 weeks old. What are you going to tell me when you put me in the scanner so you don't freak me out, but you alert me that there's a possibility of something?
You might feel a little warm sensation on your tattoo, but that's normal.
And just let me know if you feel it. Okay. All right. Anything else?
Reason for testing. They didn't write how long. You didn't write how long you've had your back problem. How long? have
Okay.
you had
So
your
you're
back
going to take that history.
Mhm.
Good. Okay. Anything else?
Prior surgeries, but you didn't specify which prior surgeries you've had. So
All
that's
right.
the flight attendant question.
Good. Yes. Go through that flight
That's
attendant
great.
question. And I'm going to tell you my surgery was my IUD. Okay.
Okay.
What
And
else?
didn't answer if you're diabetic or have renal disease.
Do we care?
No, there's no contrast.
Okay. Move on.
You didn't answer if you're pregnant or what trimester.
Leah.
What?
Look at my name.
Oh, John. Sorry.
Now be cautious
But
with
John
this. I
has
mean,
an
yes.
IUD. Why does John have an IUD?
You're right. Oh my gosh. Okay. Well, all right. So we live in a world now where some people are opposite of what they were born. So let's go with that now.
You never know.
All right. You don't. You don't. All right. Go on. Let's go past that one.
Okay, so is John a man? So I don't need to ask these questions.
Oh my gosh. So on your forms, when you get them from your front desk, they should state male, female, or I'm trying to think of what the new term is.
Sometimes people put other.
I think you're right.
Non-binary is what we say, non-binary.
Okay. Okay. So you should see that. I'm going to tell you from experience. I'm going to tell you a story I had, and I'm telling you this because this was me in a moment of like, I don't know what to do. And I live in very small town, Ohio, so we don't get a lot of transgender folks. I went out to the waiting room for an MRI knee. My patient's name was Danielle. I say Danielle, and up stands this man, like true full-on man, good looking man. And I'm like, okay, they start coming with me. We're walking back. I'm like, can you tell me your name? Can you tell me your date of birth? Like everything's matching, and I'm still freaked out.
Same
Because
same happens to me every time.
Yeah, it's crazy because some of our transgender people, they really pull it off so well. And so the whole time I'm positioning this person for their knee, I'm looking for outlines of anatomical body parts to make sure that this is truly a girl. Like I'm so lost. But so yeah, you don't always know. So that's where your name and date of birth come into play. And what do you do if your patient, like you go out and you call for Danielle and the patient comes up and goes, I prefer to be called Daniel. What do?
You check their
As far as identifying your patient? Or maybe it's a completely different name. Maybe they prefer to be called Jim.
You listen to that. You respect that. You have to go by that.
You do, but when you're using identifiers, you can't go by Jim if the patient's name's Danielle. So what way?
Name.
Exactly. You're going to ask them, can you please state your full legal name? Okay. If they've had their name changed legally, it's going to appear exactly as it should then. So that's one way to do it. So just say, can you state your full legal name if you have any questions? All right, let's see. Kari, since you're holding a little one, I'm not gonna make you think too hard. I'm going to screen you so you guys can hear how a screening actually should sound, okay? You can answer appropriately, you can make stuff up if you want, I don't care, okay? So
Okay.
now you get to be creative, all right? You ready?
Sure.
All right, can you tell me your full name?
Am I going off this patient's name?
No, don't even look at this. Can you tell me, you can tell me your real name, you can tell me whatever, I don't care, I'm gonna
Okay.
believe you.
It is Kari Miller,
Your date of birth.
04/24/1988.
All right, and you're here for an MRI of your brain.
Yes.
What kind of trouble are you having?
I'm having a lot of pain in my lower left side of my head.
How long has that been going on?
I don't know, maybe a couple of weeks.
Okay, does it radiate anywhere else? Does the pain go into your shoulder, down your arm? Does it go down your spine?
I think I don't really know.
Like, I don't know if I'm making it too hard here, but you will have patients that do that where they say, I
Yeah.
think so.
Yeah.
Does anything make it better or worse? Like turning your head one way or the other, or any type of medications?
I notice when I sleep on it at night, I feel a lot more pain like when I'm on my right side and I have it like in like this, I feel it a lot more.
Okay. All right, so we're gonna do your screening now, if that's okay. And I'm gonna run through a bunch of questions with you because you didn't have time to fill out your screening form. So just answer yes or no, and I'll fill the information in, okay?
Okay.
Are you claustrophobic?
Yes.
Do you require any type of sedation for the scan, or do you think you'll be okay?
I have a lot of anxiety, so I'm gonna go say yes.
Okay. So in this case, if you're not at a hospital, just so everybody knows, you're probably going to have to refer them back to their physician to get a prescription and reschedule them for another day. As soon as you say that to your patient, a lot of times your claustrophobic patients are willing to try. Just a heads up. All right. Do you have any dentures, partial plates, or removable dental work?
No.
Have you ever worked around metal where it may have gotten into your eyes? Any welding, steel work, grinding?
There was this one time where when my husband was doing some work, I was kind of helping him with it.
Okay. Have you ever had MRIs before?
No, this is a first.
Okay. So we're going to get a quick x-ray of your eyes just to make sure that no metallic flakes made their way into your eye, because that's a dangerous situation and can actually cause you to go blind if that moves. So we're going to do that real quick just as a safety precaution. Make sure that you're safe to go in. Okay.
Okay.
Have you had any aneurysm clips placed in your head? Any surgery to your brain? Was that a no?
No.
Okay. Hearing aids, eye or ear implants?
I have some implants, cochlear implants in my ear.
Okay. Do you happen to have an implant card with you?
Yes, let me just get it out.
Perfect. Excellent. All right. Do you have a pacemaker, defibrillator, pacemaker leads, or an artificial heart valve?
No.
Any type of stimulator, spinal shunt, or a bone growth stimulator?
No.
Electronic implant or device, insulin pump, drug or infusion pump?
Yes.
What type?
I have a Dexcom.
Okay. How long can you go without that?
I can go 1 hour.
Okay, perfect. So we'll have you remove that before we start the exam.
Okay.
Do you have any artificial limbs or prosthetics such as a leg, arm, eye, penile implant, or an intrauterine device?
I have an IUD.
Okay. Do you know what type?
I have the Mirena.
Perfect. All right. How about any metallic stents, filters, wire mesh, internal electrodes, or wires?
I don't know. I had surgery when I was a kid, but I don't remember when, but I do remember having surgery.
What location was the surgery to on your body?
It was right here.
On your arm?
Yeah.
Okay. Do you remember if it was for a broken bone or a repair to a ligament, tendon, muscle, anything you can recall?
I remember breaking my arm when I was like in 3rd grade.
Okay. Any surgery in the last 6 weeks or staples in your skin?
No.
Prior surgery with a metal implant, such as a knee or hip replacement or pins or screws from fractures?
You know what? I do have screws in my bones in my arm from that surgery.
How long ago? Oh, that was when you were a child, right?
Yeah, I was in 3rd grade.
Okay, perfect. Do you wear any medication patches on your skin?
No.
Any body piercings, tattoos, or permanent makeup?
I do have a belly button piercing.
Are you able to remove it?
Yes.
Perfect. I'll have you take that out. And again, let's see. Any prior surgeries to your eyes, to your ears, to your brain, to your chest? Any previous surgery in your body other than that arm that you've had done?
I had
Anything?
I had a mastectomy on my right side.
Okay, perfect. Did they do any reconstruction?
Yes.
Okay. And do you still have in the breast expander or is that gone?
It's gone.
Perfect. All right. Are you diabetic or have any kidney disease?
Yes, because I have a Dexcom.
Oh, that is correct. Have you had blood work done recently?
Yes, I did.
How long ago?
And that was about 6 months ago.
Okay. So we're going to have to get a GFR lab panel drawn on you just to check your kidney function. We'll do that before the test as well.
Okay.
Any chance of pregnancy or breastfeeding?
No, I have an IUD.
And any previous contrast reaction that you've had with MRI, CT, anything?
No.
Awesome. All right. Good. Thank you for doing that. And thank you for remembering what you answered yes to, because your patients are going to do that to you when you screen them because they're going to say, I told you I had an IUD. Yes, you did. All right. But that's also a good way to verify that your patient knows they're on top of it. So, all right. So that's what it should seem like if you're screening a patient for the first time, because you want to be able to go through those questions pretty quickly, almost that rapid fire, but know when to stop and ask the appropriate questions. So metal in the arm placed at like whatever 3rd grade, she said, the scar tissue that is in there now, that metal's not going anywhere. It is attached to the bone. There really wouldn't be a concern for us to even x-ray that because it's had years and years and years to heal. Even if it wasn't attached to the bone, it's not going to go anywhere. So we would not be concerned with that. It's not going to stick her arm to the magnet and she's not going to be able to come off or anything like that. So, all right, guys, we'll take a break from the screening forms. What I got here. All right, let's look at the spine again, just to review what we've kind of already learned. So we're up in the, what region are we in? So, well, it's cervical spine. It says. Yeah, I'm like, it says it. Never mind. What scan plane is this?
Coronal.
Coronal.
And this one?
Sagittal.
And this one.
Axial.
Anybody remember the landmark for the cervical spine? We learned this when we started talking about coils. Mid-neck or 1 to 2 inches below the chin in the chin down position, because usually their chin is going to be kind of angled downward. The odontoid process of C2. Why is this an important landmark for us? I talked about this earlier. Why do we like C2?
Because it lets us be able to count.
Yeah, exactly. Once you identify that, you know how to start counting your vertebrae. So it is an important landmark, even though it's an internal landmark that we can't see on the outside. We need that to count our vertebrae. All right. So we have some stuff labeled here. You guys already learned this, but here's that anterior arch of C1. Let me make it a little bigger for you. Anterior arch of C1, our odontoid process, of course, sticking up. Here is our posterior arch of C1. You guys all know this, spinal cord, CSF around the spinal cord. What weighting is this? What scan is it? There we go. Good. Yeah. First time we got to see a T1 on here. Here is our, well, what is this? I don't have this labeled. You guys tell me.
Intervertebral disc.
Intervertebral disc. Which one?
C5.
With C5, C6.
There you go. Remember, it has to have the name of the vertebrae above it and below it. C5, C6 vertebral body. What is number 3?
Body.
Of what one?
C2.
C3.
Ah, this one's actually C2. You can see just a little bit here of this separation, but this is actually C2, and then the odontoid is actually extending upward. It's kind of tricky because sometimes you get that little bit of a line you can see, and it looks like it's chopping C2 in half, but it's actually not.
Where's C1?
C1, we can only see the anterior arch of C1. Okay.
Okay.
And then this is our odontoid process, which is part of C2. Okay. And this is C2 as well. Did I say C3 a minute ago? Tell me if I did. I feel like my brain. Okay.
No,
All right.
you said C2.
I'm like, I'm questioning myself. I'm like, did I say C3? Yeah, C2. All right. And yeah, you guys know all of this. How many vertebrae are in the cervical again?
6,
7.
7.
7. So we have some hints here. You may have heard other professors use this as well.
7,
They
12,
often do it.
5.
So, yep, breakfast, lunch, and dinner time are your hints. So 7 a.m. is when we eat breakfast. Well, not me, but some people do. So that is going to be how many vertebrae are in our cervical. How many thoracic vertebrae do we have?
5, 12, 12, 12.
12. Good redeeming.
12.
And how many lumbar?
5.
5.
How many sacrum?
4, 3, 5.
3, 4, 5.
Sacrum.
It's fused.
5.
12.
5.
Actually,
Yes,
5.
and the transverse processes of the sacrum are fused together to form the lateral masses. You are correct. And how many coccyx do we have?
5.
5.
Anywhere from 3 to 5. That one can vary.
Oh, sorry.
All right. When we talk about setting up slices for a sagittal cervical spine, I know we have not gone over this, but let's see what you can figure out on your own. When we are setting those up, what imaging plane would we have to set them up from? So remember, sagittal is going to divide the body into left and right.
Mhm.
So which imaging plane can we see the vertebrae from left to right?
Coronal.
Coronal. Exactly.
Right.
Yep, you have to be able to see. If we're doing sagittal scan, it means we're cutting the body into a left and right portion, and we are scanning from the left to right of that anatomy. So we have to be able to see all of the bony anatomy from left to right to make sure we're covering it. So yeah, we will set up slices on the coronal. Landmark for the thoracic spine. Anybody remember this?
This is the vitamin E.
That
Well,
the
no, that was used to help you count and localize where you're at. But what is the landmark?
Notch of
Landmark.
sternum.
Mhm.
that be your clavicle? No,
So it's actually mid-sternum.
mid-sternum.
Mid-sternum, oh, yeah.
Mid-sternum. That's going to put you right around T4, T5 roughly. That's just an estimated area, but it's going to be mid-sternum. So right between your xiphoid process and your suprasternal notch, come to the middle. That's where you want to center. All right. What is this right here? Who knows?
Saturation band
Saturation band. Why would we use that?
to take away the, is it the, not the, well, would it be depending on like the veins, right, and the arteries?
Well, you're thinking of how we use a saturation band in the brain to avoid venous contamination or arterial contamination, but we can use saturation bands to minimize motion as well.
Okay.
So this is to prevent that motion artifact from those lungs that are constantly moving while we're imaging.
Hmm.
All right, good. Let's look at the lumbar now. What's the landmark for the lumbar?
Belly button.
Top.
I heard belly button. Any other ideas? Are we all in agreement with the belly button?
If it's the, would it be by your pelvic?
Yeah, the iliac.
All right, so this is going to be 2 to 4 inches above the iliac crest.
Yeah.
But Karin is correct. If your patient is really large and you can't feel that iliac crest, because that's what you're feeling, those upper hip bones, if you stick your hands in your sides and rest your hands on your hips, that's your iliac crest. But if you have a 400-pound patient who's 5 foot tall, are you going to be able to feel the iliac crest? No. So tell your patient to point to their belly button. And that's where you're going to put your laser landmark. So it's an easy way to do it. Let's see. What is the area represented in green? What part of the spine is this?
Sacrum.
Sacrum. And the last lower part here, what is that?
Coccyx.
Coccyx. All right, what is the landmark for the sacrum coccyx? Anybody remember? 4 inches below the iliac crest.
So that would
4
be your
inches.
pelvic area, right?
Yeah, it's about mid pelvis, honestly.
Okay.
So 4 inches below the iliac crest. Again, you can have your patient point to their belly button and go about 4 inches below there. Especially if somebody has that larger apron on their belly that hangs down to their legs. Sometimes it's really hard to find the pelvis. So yeah, just have them point to their belly button and go about 4 inches below there. And in this image here, what are the blue lines representing?
The sacrum.
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 Sacrum. Excellent. And the tailbone is known as what?
Coccyx.
Coccyx. I'm not going to dive into shoulder because that's just a little too far ahead right now. So I'm not going to overdo it with that one. Let's talk about an MRA cow here. Let's see. What does MRA stand for?
Magnetic resonance angiography. I can't pronounce it right now.
Angiography.
There you go. We pieced it together, guys. That was teamwork for certain. Magnetic resonance angiography. So what are we focusing on?
Arteries.
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 What does CAL stand for?
Circle of Willis.
Excellent. What is the difference between an MRA and an MRV?
Arteries versus.
Arteries in the veins.
Perfect. Anybody know what the MIP stands for?
Oh,
Which? Oh, me.
MIP, MIP.
isn't that? Oh man.
We talked about it this week in lab a little bit. Well, this is something we do post-processing on our MRA cow.
It's like the cutting, right? The cutting.
Yes.
cutting of the
So when
blood.
you hear us refer to MIPPing, we are simply using the scalpel tool to cut out all the information that we don't want to send to the radiologist. And it stands for maximum intensity projection. So maximum intensity projection. And again, it just allows for us to do that snipping technique. Does anybody, I don't know if we've talked about this all, but the 3D time of flight sequence when we run an MRA brain, this is when we're putting that slab from the foramen magnum just above the corpus callosum. It's actually a slab. It's not just individual slices with a gap between them. This is a slab of slices, very, very, very thin slices that are literally touching each other. There's no gaps. And when I told you guys before that when we do an axial brain scan, there's about 30 slices roughly from vertex to the foramen magnum. For an MRA circle of Willis, even though we're cutting off the top of the brain, there's about 120 slices in that setup. So this is why the exam takes a long time to run. Again, on average about 5 minutes, but can go upwards of 10, 12 minutes on an older scanner. And why do we use the saturation band on our MRA of the circle of Willis?
To cut the blood from the
To cut
blood
the
from
fat.
coming, or
What was it?
to keep the blood from coming in. So,
Okay, well, remember we have the circle of Willis for imaging, which has blood. But what are these blood vessels that we want to avoid getting any reading
Fat.
from?
Veins.
Veins, yeah.
Oh, veins, yeah.
Yep, it's the veins. So we're going to put a saturation band superior to the slices because we want to avoid venous contamination from the veins. Now, if I was doing an MRV and I want to see veins, where am I going to put my saturation band to avoid Yes, it's going to be inferior. It's going to be on my neck to avoid arterial contamination. Good. All right, a little bit of pituitary anatomy. Hopefully you guys remember some of this from last week. Sphenoid sinus is given, so that's an easy win for you. What is this area circled in orange?
the
Eagle artery.
Which artery is it?
The right.
Vertebral.
Right internal carotid. Good, right internal carotid. What is this area here?
Pituitary gland.
Pituitary. How about this little line?
Is that third ventricle? Huh?
This is that little branch that extends off of the pituitary to the hypothalamus.
Oh, the
Hypophysis.
Tentori, no?
Not tentorium, no. Anybody remember? So it's our pituitary stalk. It's called the infundibulum. The
Oh.
crazy wonky name, infundibulum. What is the area circled in green?
Optic chiasm.
That is right. So where our optic nerves come back and they cross, that's called the optic chiasm. Good job. Let's see, screening forms. We did the spine. We did worksheets.
There was I remember, I think you were talking about how as MRI technologists, like you guys were like nervous for like the blood to like go up to the brain, and we have like to time it. What was that again?
That's the MRA of the carotids, the blood vessels that go up our neck. That is a contrasted exam. So you have to have your timing down and be able to start that scan right on time to catch that contrast going up. You can start too soon and miss it entirely because it's not going to be, you're not getting it on time. So it's not going to be saturated enough. Or you can wait too long and it's completely gone. And now you have all these veins as well because it's draining back down. So your timing has to be absolutely spot on for those. So your techs are typically like kind of patiently tapping on the table, waiting to hit their start button. So yeah, you inject a bolus, at least 2 mLs per second. You watch it come into the heart. And as soon as that flash starts up those major vessels off of the aortic arch, you start the scan. That one makes you
name like for that.
Is there what?
Is there like a specific name? Like
that's like MRA carotids.
Okay.
MRA of the carotids. Yep. All right. Let's go back to the screen form just for a couple more here. Karin, giving you a screening form. Just treat me as your patient and ask me anything you need to ask me.
I have to ask, or
I'm your patient. I just handed this to you. So now you're going to do your verbal screening.
So I'm going to explain you about like sedation that is required for your claustrophobia.
So be careful with this one, guys, because you may be at like an outpatient facility that doesn't offer sedation there. So when you see this, your first question, even if you do offer sedation, is did your doctor prescribe you something to take?
Oh, okay.
Okay. So that's what you would ask. And then if I say no, and you're at a facility that doesn't offer sedation, you're going to have to tell me you'll have to reschedule me. I'll have to go to my ordering doctor and get a prescription and reschedule. Now, if you are at a facility that offers sedation, typically they're going to screen patients ahead of time to tell the patient to come early so you don't get super backed up. But first question you should always ask is, did your doctor prescribe you something to take? Okay. All right. So we're going to say, yes, my doctor gave me something and I already have it. So you can go ahead.
Okay. And then, so you have artificial heart valve?
Yes.
So I have to check make and model through the MRIsafety.com. And if you have any records, is it MRI conditional or unsafe? I will see. So
okay, how are you going to check?
First of all, medical records or records from the manufacturer, if you have it, or if your records like has it, and then through the MRIsafety.com.
Okay. Easiest thing to ask me, first thing you should ask me, do you have an implant card?
Okay.
You know why that's the easiest? Because when someone hands you an implant card, it has the safety classification. It'll say right on it, MR conditional. And then it's going to provide you with all the conditions right there. And you won't have to go do any research at all. If not, then you are correct. You need to call and get my operative report from the hospital that did my surgery. And then you're going to take that information and research it. What information are you taking from the operative report to research my implant?
Oh,
What do you
make
need?
make and model.
Excellent, right there. That's what you need. Always be careful when you research to put in the exact number the way it is too. Make sure that you don't accidentally put in the wrong number. If you do, it's probably going to come up with a totally different type of implant, but just always be cautious. Double check, triple check. Okay. All right, go on.
So electronic implant devices, insulin pump, drug infusion pump, removable. So it's yes. Is it removable? And what do you have?
I have an insulin pump.
So yeah, how long can you go without insulin?
And go 2 hours.
Yeah, are you okay? We have to remove the pump.
Okay.
And next question. So are you you can you disagree? Actually, like I don't want to
Like to
remove
remove it, you mean?
yeah.
Yeah, I can say I can't take it off. Or I don't feel comfortable taking it off. Yeah.
So
What are you
then
going to do if that happens?
I can't do MRI with
Correct.
insulin pump.
And the patient's probably going to get angry and be like, well, why? I've had this test before and they scam me with my insulin pump.
Because first of all, it's dangerous for your health, and second of all, we're gonna have destroyed your insulin pump.
But I just had this exam, this same exact exam 4 weeks ago at another hospital and they did it. Why can't you?
They remove it, I'm sure.
No, I didn't remove it. I'm telling you, I had this same exam of my abdomen and they did not remove my insulin pump.
It means they just turn it off.
No,
Or
I didn't turn it off.
it means it doesn't have any electronic part or metallic parts in it.
No,
So
it has a battery. It has my medication in it.
I have to check. Is it safe or no? Can I?
There's no implant card or anything you're ever going to get on an insulin pump. So your patients often do this, and you know why? Because she just had a CT 4 weeks ago and thinks it's an MRI.
Oh, I wanted to
It's
say
that
that.
little, yeah. And see, that's the thing. You should and follow on that and say, you know what? You might have had a CAT scan. It's very, very similar, and it's so easy to think they're the same thing. And so for our procedure, we have to remove it to be safe because it actually can release all the insulin into your system at one time. It's going to probably break the insulin pump. It's going to kill the battery. And if it has metallic components, it's going to get pulled off and it may bounce around in the scanner and bust into a million pieces. So we can't do it. And usually your patient will then go, oh, you know what? I think it was a CAT scan. But patients will get agitated with you and they're going to be forceful and they're going to say, no, I just had this done. So just easiest thing is to say, you know what? It's really easy to think, you know, that your CAT scan might have been an MRI. I'm assuming that's probably what was done. And they may still disagree. And you just have to stand your ground. You're not going in there with it on, period. Okay, go ahead. I'm sorry, I did that to be difficult on purpose.
Yeah, it's very helpful. So electronic implant devices, yeah, so we call it metallic stent, filter, wire, mesh, internal electrodes or wires, location, abdomen. So again, I'm gonna ask the medical record or implant card if
Well, there's another question you should ask first.
oh, where is the exact location?
It's in my abdomen.
Why is
Notice
it
there's multiple things on here though. So you should start to try to eliminate some of those. Which
yeah,
one
yeah.
do you
Which
have?
which one do you have?
Okay, so I'm going to say I have a wire in my abdomen.
So No.
And then what should your next question be?
Do you have any records or implant card about that material that wire
No,
is made in?
no, I don't have any implant card for that, no. So next question should be, what is it used for? What purpose does that wire serve? Because now you're going to make them generate some sort of answer. Okay.
Mhm.
So, because
So
you're thinking right now, this wire is inside their abdomen. So what was the wire placed for? When you ask that, my answer is going to be, well, it delivers insulin to my pancreas. And what's going to happen in that moment?
So it's related for your insulin with your insulin pump.
What
And
do we
then
know about?
Is it removable?
No. What do we know about insulin pumps and what goes into the abdomen to deliver the insulin? Is it truly wire?
No, it's tube.
It's a tube. So that's
And
the
it's-
moment where you go, oh, you're referring to your tubing from your insulin pump. Yeah,
and-
yeah, that's what I'm talking about. Oh, well, I put that as wire. Because
Yeah,
your
but-
patients are going to mark things that are wrong that they don't have because they just think it means something along those lines. So just, this is where you got to dig deeper. Okay.
So insulin tubes are safe, so we know that, and it's not. I don't think it's metallic.
Great. They can stay on, but it's getting to the moment of realizing, oh, you don't have an actual wire. You're talking about your insulin tubing. So it's that moment that you realize, okay, they just put that because they thought it was indicating like something into their belly. People will do that. All right, what else?
So body piercing, tattoo, permanent makeup, ears. Do you have piercing on your ears?
Yes.
I will check it with a hand magnet. If it's ferromagnetic, you have to remove it. Or anyway, if it's removable, can you remove it?
That should be your first question. Can you remove it? Because we want to remove everything we possibly
Yes.
can.
Mm-hmm.
Yep. So that should be your first question. If not, then you're going to get your portable magnet and check it.
Mm-hmm.
Anything else?
So you are diabetic. It means
Yes.
We don't use gadolinium. I'm in
Are
contrast.
you sure? What exam are we doing?
Oh, liver.
Are we using contrast? Look at the exam. The answer's right there.
With or without?
With and without. So you are doing a contrast exam. So why do we care about being diabetic?
Because of
What can happen if you inject contrast and I'm diabetic? What can happen to me?
just renal failure.
You say just renal failure, like it's not just renal failure. It's fine. It's fine. All right. Why? Why would we be concerned with renal failure if I'm diabetic?
It will be cause of nephrogenetic.
It can cause NSF, yes, but why? Why would me being diabetic be a risk factor for NSF?
I don't know. I don't remember.
Diabetics have very, very poor circulation and they often have very poor kidney function. They are known to have poor kidney function. So what do you need to do to make sure I'm safe to inject?
Oh, GFR lab order.
Yeah, yeah. So I have to have my GFR drawn. What are we looking at specifically when a GFR is drawn? What blood level?
So if GFR is below 30, it means we can't do contrast. If it's above.
If
we
it's
can-
above 30, we're good to go. Yeah.
Yes.
GFR is a lab panel. It's not actually what's being checked per se. I mean, it is, but it isn't. What are we drawing that they're getting the calculation from for the GFR? Do you remember? It's a kidney test that's drawn in lab.
The ability of filtration of kidneys.
That is the lab test we're getting, but they're going to use our creatinine
Oh yeah,
to get that
creatinine.
calculation. So our
Mhm.
creatinine. Okay, is there anything else we care about?
No.
All right, look up top. There's one area that you should verify.
Oh yeah, your weight,
Why do we care about my weight?
because so in case if you are okay for a contrast, I have to measure the amount of gadolinium. So in this case, it's almost 20 in maximum 20 milliliters. If calculation shows that it's above 20 milliliters, I can't go over 20.
Correct, yeah, so you're gonna give me a dose of 20 ml. That's right. Why else do we care about my weight?
Potential danger of falling or broken table.
Ah, there we go. Our table weight limit, a lot of our weight limits are only 350 pounds. Some will go up to 600, but you need to make sure that you have a table that can support this person. All right, so we've got weight limit, we've got our contrast calculations. What else? There's one more thing.
There's nothing.
So there's 3 reasons we like to have weight. As you said, table weight limit.
And burns. I mean, using cushions and so. Am I right? Or transportation?
So it is SAR.
Oh yeah, SAR. You have to
SAR is our
calculate
concern. What is SAR?
SAR is sound.
All right, Karen, we're gonna phone a friend because I've picked on you long enough and I think I've turned your brain into jello because I can tell you had a hard one. So I'm gonna give you a breather. All right, is it Michael or Mikhail?
Mikhail.
Okay, I want to make sure I have it correct. What does SAR stand for?
It's the specific absorption rate.
Oh,
All
yeah.
right, Michelle, what is specific absorption rate exactly?
Oh, I think I need a refresher, but does it have to do with burns?
It does. This is why we care. We don't want to burn our patient, but what is SAR? How does it cause burns?
Sorry.
And it's okay if you don't know. That's why we're doing
Yeah,
this.
I don't know.
All right, who knows? What is it?
So because of eddy currents and moving of blood, I mean, we can get.
We can
burns.
get burns from eddy currents, but that's a little bit different.
Is it that
Who
RF
knows?
pulse?
It's
Right,
the,
so-
it's the rate of how it's absorbed into, like, the energy absorbed into your body.
So this
too.
is our heat deposition. This is how much heat is being deposited into the body. Okay, remember B1, our radio frequency pulse, is what is creating that heat. Okay, and we're hitting that patient's anatomy over and over and over with that RF pulse. So their body temperature is going to start to increase. So that is what we're measuring. What unit do we use to measure it? Main. I know I say your name wrong every time. How do you actually say your name?
That's fine.
You're like, it's fine, just go with it. All right. So what do we
Measure-
measure?
Watts
Sorry.
per kilogram.
Yes, watts per kilogram. Excellent. Let's see. All right, so we're gonna take a breather again from these, and I'm just gonna do some quick questions before we hop off. Ryan, do we scan pregnant patients?
No,
Never?
depends on how many months are they.
Okay.
I think it's, what was it? It's, if it's the first trimester, then no.
Okay, so we typically don't want to scan at all in the first trimester if we can avoid that. But any trimester, we're still going to try to avoid it unless it is benefit outweighing the risk. What is a reason we would do a pregnant patient any trimester? Jasmine. What type of diagnosis could a pregnant patient have in their first trimester that we would say, okay, we're going to scan this person? I can't hear you. For some reason, you're not.
Sorry,
There we
my
go.
it just doesn't work. So I would say you'd probably scan them if it's like if it's a risk for their health, you need to scan them.
Yeah, but do we know any diagnosis in particular? We talked about this one time in lab class, so it's okay if you guys didn't catch it. Does anybody know? What would be a reason we would scan a pregnant woman in the first trimester? We often get called in the evenings to do these exams, or the middle of the night. They like the middle of the night too. Appendix.
Oh.
So if your patient has a possible appendicitis, they're going to send them to MRI because we do not use ionizing radiation, and all the fetus would get would be tons of radiation looking for that appendix. So we would actually do an appendix scan on a pregnant woman at any period in time. After the first trimester, we would scan pregnant pregnant women, typically if it pertains to the actual pregnancy itself, like looking for placenta problems. Or again, if it was another appendicitis, they might be far along and we would actually scan for that. It is hard to scan a pregnant patient with the fetus moving. So one thing we do to kind of try to calm that movement is we do supply oxygen to the patient while we're scanning, because it's shown to be effective as far as increased oxygen to the mother seems to keep the fetus from wiggling all over. But a lot of times that loud noise is enough that baby starts to squirm. But if you're looking for appendix, it's outside the uterus, so not such a bad thing. What is the landmark? Michelle, what is the landmark?
For the brain, it's the glabella.
Just in general, what is a landmark? Not a specific one.
Isocenter, where you want to line up the part you're scanning.
Okay,
inside the
so we use that laser light, and if it's the glabella, we're going to put the laser light right there. What does it tell the scanner to do?
to scan the brain.
Okay, so you've lined up my laser light. You've hit the advance button. What's going to happen to this area that you just marked? Where's it going to go?
What do you mean?
Well, was the landmark when you put the laser light on, was that isocenter?
Yes. Right between your eyebrows.
That is not isocenter.
Okay.
And that is a good thing to actually go over, because a lot of you probably have gotten that confused. So a landmark is literally an external body part that we use those laser lights to landmark, to tell the scanner, this is the body part I want in the center of the bore. Isocenter is the center of the bore. So if it's your glabella you mark, this is going to land right in the middle of that scanner. If you landmark my lumbar is going to land in the middle of the scanner. Okay, so that is isocenter. The very center of the bore is isocenter. Your landmark is simply telling the scanner where to stop. Okay. I'm actually kind of glad you said that, because that's something we kind of overlook as instructors. We take it for granted because we think it's so simple, because it's something you do every day when you're out there, and we overlook that. So I'm glad we caught that.
So basically, landmark is the mark on our body, and the isocenter is the center of B0.
Correct. Yeah. So a landmark is an external portion of the body that we can see. Okay. So again, glabella, we know it's right here, 1 to 2 inches below our neck. We know it's right here. And that is where you're going to put those laser lights at. But once you do that and you turn your laser light off, you're going to hit advanced to scan on the scanner, and it's going to move that table in, and that exact part that you marked is going to land right in the center of the scanner. Because if you just landmark whatever, their body's not going to be inside the scanner. So we're not going to be able to actually get anything from that. So that's what it's telling the scanner to do. It's telling that table, I want you to stop right here when it gets to center. So it's telling it exactly where we want it to stop. Who do we screen?
Everybody.
Everyone. I was waiting for y'all to yell that one. Yes, we screen everyone. If I said I had a knee replacement, what do you need to ask me?
When?
How long ago?
How long ago, and how long does it need to be?
6 weeks.
6 weeks and longer.
3 weeks. 3 weeks post implant.
Confused.
Because they're, what's that?
Which one's 6 weeks? That has to be
6 weeks is like our coronary stent, something that's in a vessel that the scar tissue needs to build up around. Your implants, your plates, pins, or screws from fractures, they're attached to the bone. They're not going anywhere, but we do want to give them that 3 weeks just to have a little bit of scar tissue build up. But of course, if benefit outweighs risk, you may scan them right after they get it done. I feel like we have hit on literally everything. I don't have anything else I think that we have not already talked about. So it's already been 2 hours. So you guys are free to go. I will send this recording to everyone. Remember, if you're going to keep this for future use, you want to download it to your computer because it disappears after 8 days. Okay. And I will hang out for a minute if anybody has any questions. But other than that, thanks for coming, guys. And you are going to rock on your clinical interviews.
Oh,
Thank you so much.
Oh, no.
Thank you.
It's so
You're
excited.
welcome. Yeah, I
Thank
know.
you.
I know. Bye.
Bye.
Thank you.
Thank you.
Yep. Have a good one.
Oh.
Questions?
I'm sorry.
Are you guys sleeping with your eyes open?
No, I was.
Karin, you look oh, he's gone. I was gonna say Karin looks exhausted at this point. Like he's just like, I'm done. Peace out.
I know. I was just wondering about that landmark. So that was to stop, right? So I was just because I was like, wait, I don't remember going through that.
Yeah, and sometimes that's an easy thing that, like I said, as instructors, we kind of take for granted and forget to mention that when you landmark a body part, you're telling the scanner where you want it to stop.
Okay.
Yeah, so if you guys, I don't know if I've told you all, but MRImaster.com is a really great website to go to. It has every protocol that you can use in MRI. But like if you click on MRI brain, they actually have a video that you can watch where they actually put the patient on the table, set them up, landmark them, advance them, and scan them. And you can actually watch the scan as it's happening, which is really
Yeah.
cool.
I think Matt went through it with all of us last time, but it was like too slow. So we were like, what were we waiting for? So I mean, it did work. So
and you know what? It's really a good tool to use before you do your midterm in lab, because then you're going to be able to look at that and go, okay, I need to do this. I need to do this. I need to do this, because your lab midterm is graded harshly. It is not graded like your weekly videos. So if you are struggling with videos, prep for that midterm, because
no, you told
it
me
is
earlier.
very, yeah, I've never given 100%. And I'm telling you, we grade them harshly because now we want to see that you are putting together the pieces and you understand what your circumstances are and how to deal with them, and you're prepared. So be ready, but seriously, go watch some of their videos on MRImaster.com. And it's going to show you like step by step once you get the patient into zone 4, what to do. And it's just a really good guide. So why not?
All right.
All right,
Thank you,
study
Miranda.
those. Yeah, you're welcome. Study those screening forms because Miss Daniela is going to have those and you're going to have to be able to read through them and discuss them. Okay.
So I have a
Thank
quick
you.
question for like
Sure.
the clinical interview. It's gonna be like, you know how we went over the screening forms, it's gonna contain like that and then a little bit of anatomy, like what we covered tonight.
You know,
Or-
Daniela changes it up all the time. So there may be anatomy. Typically it's going to be brain or spine, one of the two for her, because she usually hits on something that you've already had in class and you guys are just now doing brain.
Right.
But you had brain and spine anatomy last module. So honestly, she could
Yeah.
do anything, but typically it's brain or spine.
Okay.
She's going to show you a screening form. She may show you a physician's order, just like we did tonight. She just may
I
ask
know,
you
I'm like,
questions.
oh, I got so stuck on it. I'm like, just
And that's the
nerve-wracking.
thing. We want to see you guys confident in your answers. And so you'll notice we often try to make you question yourself, you know?
Yeah,
So
and
like
it does.
saying,
And I'm like, I do it already. So it's like when I'm in that moment, I'm just like I
And that's-
feel like I freeze.
and that's what patients do to you. So that's why
Mm-hmm.
we do it. So that's the same thing. Like when we say, hey, what would you do if a patient said they work around metal? Well, you're going to
Mm-hmm.
say, well, I'm going to get an x-ray of their eye. And then I'm going to say, okay, well, it's just a tiny piece of metal. So we can still scan, right? And a lot of times that's just enough to get the person to flip their answer and go,
Right.
yeah, if it's tiny, yeah, we're good. And it's like, no, I just tricked you. I made you doubt yourself and you weren't confident. And so
Yeah.
that's what we're looking for. You are confident and you feel like, no, you have a piece of metal in your eye. You're not going in zone 4 ever until it's removed.
Mhm.
So just confidence, you know, if you even if you're wrong, but you're still showing that you're confident and you're sticking to it, and you're like, no, this is it. This is what I believe it to be. That's better than the wishy-washy of, oh God, you're questioning me. Like, yeah, no, you're right. You can do it. No,
Mhm.
no,
So you
we're just
have
tricking
any
you.
like, do you have any like tips on like how, like just going over the material over to feeling like that confidence and
It's repetition. It is honest to goodness repetition. And so like I often tell students, especially like implants, you need to know your implants inside and out. Okay. If a patient leaves something blank and they say, well, what is a pacemaker? And you're like, I'm not sure. And your patient picks up their phone and is like, hey Siri, what's a pacemaker? Now that's bad. You know what I mean? You
Mhm.
need to show them that you are confident, you're capable, because when you go to your clinicals, you're really not a student anymore. You're an intern now.
Right.
And you need to present yourself as confident. And like, even if you kind of just use a lot of words and get your way through the description, it's still better than going that, oh, I'm not sure, you know, we want you to have some idea of what it is. So
Okay.
implants, I always tell students, put the name of the implant on the front of your index card, print off a picture of the implant card so you can see it as well on the front.
Okay.
And then have your facts on the back about it. You know, if it's a
Mhm.
pacemaker, it's going to say, you know, it has 2 pacer wires that also need to be checked for safety.
Okay.
And they're going to extend down into the heart and they're going to stimulate the heart to be at a normal pace. So just try to do that. Those index cards will be good. Any of the questions we ask you over and over, you know,
Mhm.
screening questions, write down every screening question, you know, are you claustrophobic? If the answer is yes, what are you going to do? You
Mhm.
know,
Okay.
do you have a pacemaker? If the answer is yes, what are you going to do?
Mhm.
And be
Okay.
confident, you know, and know, you know, if a patient has an implant, first thing you're going to ask, do you have an implant card? No. Okay. Second thing, I'm going to go get the operative report from where it was done at. Third thing, I'm going to get the make and model number from that report, and I'm going to go to mrisafety.com and I'm going to put that in and I'm going to check to see if it's safe or conditional or unsafe. So
Okay.
it's just having those down so that you can tell us, because
Okay.
everybody does. They get to us and they freeze.
Yeah, like, oh, it's so terrible.
Yeah,
Thank
yeah.
you,
It's
I
hard. It's
appreciate
hard when
it.
you're on the
It
spot.
is.
So
It is.
yeah, absolutely. I will send these videos to you as well. Okay.
Okay.
It may
Have a
be in
good
the morning
night.
though.
Okay.
All right. Have a good one.
You too.
All right. Bye.
Bye.